Hello, good morning. How are you? Hope all you are doing good. I'm also keeping good. So today I came with another topic, like a Decubitus ulcer, or otherwise we call it as a pressure injury or a pressure ulcer. So here I bring this class as a slideshare because this class I need to show you that different of skin alterations and skin injuries as a picturization. I need to explain it as well. So that I try this way, and then let me know whether it is very useful to you or you can able to follow this class, or whether there is any need of improvement in this. Okay, so okay, come to the topic. Decubitus ulcer. So decubitus ulcer, as you know, if you are working in a healthcare industry or in as a nursing personnel, so you if your care is more effective, or you are giving care to the person or a patients with those who are in a chronically ill, those who are in a bedridden, if you are giving your care more effective, you may not be experienced with this. So you have give a skincare routine, following the skincare routine, and then you are following the protocols, and you are turning the patient, and then remove the pressures and sheaths and everything, and then avoid moisture, and your fear care is effective to the patient, you will not be experienced with this. So if the occurrence of a decubitus ulcer or occurrence of a pressure injury to your patient, if it is a hospital acquired, so this is very notable to as a nurse, we are lacking in some way to providing a care to the patient. Okay, so in this video I just give a brush up to you, or I just improve, it helps you to improve your knowledge or brush up your knowledge related to this topic in a simplest way. So we can see in this class what do you mean by the decubitus ulcer, and what are the stages, how it will be, and what are the care we need to give, and what may be the signs and symptoms, and how you have to do your assessment, like that. Okay, so following slides, it will tells you about these. Okay, so at the end of the class, hope you understand what do you mean by that, and what are the stages, and what kind of a nursing care I need to give to the patient which is comes under you. Okay, so we'll go to move on to the classes. Okay, so decubitus ulcer, it is the form of a traumatic ulcer due to the direct pressure on the bony prominence of a person. It may lead to the vascular compression and then tissue necrosis and ulceration. So in a Latin word, decumbre means it's to lying down. So you might have seen this ulcer, mainly this has happened to a person, those who are in a lying down for a prolonged time of a period in bed, mostly in a chronically ill patient with a ventilator support, patient with comatose, and patient cannot able to move from their bed, like that. Okay, the GCS level is low, so like that patients only it will be happening. Synonymally, we are name it the decubitus ulcer as a pressure sore, tropic ulcer, ischemic ulcer, and necrotic ulcer. So usually we call it as a pressure sores or a pressure injury because of these lesions. Okay, so mainly this is happening to a person with a prolonged lying down persons only it will be happen. So when you move on to the definition, the pressure ulcer or the pressure sore or the decubitus ulcer or the bed sore, it is a localized injury to the skin with underlying causes to the skin and other underlying tissue, usually over a body prominence as a result of prolonged unrelieved pressure. Prolonged unrelieved pressure. So that only we ask you to change the position every 2 hours. So So if you're doing a turning, or if you're changing the position of a person, it will helps you to relieve the pressure at the back. So when the pressure is relieved, the skin which is under the bony prominence, and it will helps to remove the pressure. It cannot be hurt more as soon as possible. Okay, so this slides we are going to study about why the pressure ulcer is develops. There are so many things, or so many mechanisms, or so many things which is corresponding, or which is lead to a pressure injury, pressure ulcer. Okay, the first one is friction. Friction means the two object which is moved together in the opposite direction, that we call it as a friction. And shear, it's a compressed pressure, impaired sensory perception. The patient doesn't know the lack of sensory level, and the impaired physical mobility, bedridden patient, altered level of conscious. The GCS is lower than the 8 or 7, and the altered level of conscious, and then fecal and urinary incontinence. Is it that the continuously wet? It may lead to the moisture, MSD, and it may lead to the pressure ulcer. Malnutrition, lack of nutrients, lack of protein, and that may prevent the skin fold become thin, and then the patient may be developed with a less skin density, and it is easily provided with that. Okay, dehydration is leads to dryness of the skin, and due to a friction effect or due to other effect, it may leads to easily tearing of the skin lesions. Excessive body heat, that is excessive sweating, so that the person may develop with a wetness. It may lead to the moisture related pressure injury over the skin folds, and over the inner parts of the folds of the skin, and then inner parts of the body. Advanced age. Advanced age, the skin fold lost their fat, and then the level of protein is very less and fat is very less in the skin folds. It may develop with a, or easily chance with the pressure ulcer, because the loss of skin density and texture of the skin. Chronic medical conditions, like the patient with a ventilatory support, and the patient cannot able to move from the bed with lots of tubes, and then lots of invasive, non-invasive monitorization, cannot able to move from the bed. We cannot able to change the position of the person frequently. So this may prone to develop with a pressure injury of a person. Okay, next we move on to the pathophysiology. Okay. So when you come to the pathophysiology, so this pathophysiology, it is why it is happening. So here we are having a two kind of factors, that is precipitating, predisposing factors, and then contributing factors. Predisposing factors, the mainly we are see here is a sensory deficit, impaired physical mobility, and then altered in the level of conscious. So this is the predisposing factors. Excuse me. And then contributing factors, chronically medical conditions like a stroke, diabetes, and then cardiovascular disease, advanced age more than 79 years of old, and then excessive body heat and malnutrition. So these are all the contributing factors. So mainly the two factors which is lead to a pressure ulcer, that is a predisposing factor, and then the contributing factors. So this is the main things. So here when we come to this, that may leads to so many things, or so many mechanism, or so many factors due to this. So here you can see the first is the patient within a bedridden, or the patient is in a chair fast, prolonged in a wheelchair, or the patient has a involuntary muscle movements, the Parkinsonism, you can see there is a tremor, and then those who are has a delirium or dementia or neurological deficit, it may leads to the involuntary muscle movements, and then passive repositioning the of the torso. So passive means actively they cannot able to move by themselves. They need helps to move or to turn from the bed. Okay, and then inability to move well or aging the skin tone, a loss of sensitivity or ethnicity of the skin. So it's mainly a bedridden patient or mainly a aging patients. So the density of the skin is very low. And then the bowel and bladder incontinence, diaphoresis and wound drainage. So here it mainly related to the moisture related pressure injury. So due to the wetness, as you know already, if you are washing your clothes or if you are keep your hands prolonged in the wet, what will happen? The skin of your hands, it is become very loosen or it is prone to be rupture. So likewise, if it is the person is past the motion as a loose, or the person is has a urination, so what will be happening? The area of the genital area and the anal area, which is the skin, is become more thin and easily break down, so that it will be happening. And then it is disease in the movement. So CVA patient and then coma patient post surgery cannot able to move their body parts due to that. So the pressure is remain at the back, so that it may leads to the pressure injury. So when the person is in a bedridden or in a wheelchair, what will be happening? It may lead, it produce the external physical pressure to the person. Or if the person is in an involuntary muscle movement, there will be a shear force. The force is like a it's down like that, and then inability to move the wheelchair, friction will be occur, and then incontinence, moisture will be occur, sin maceration will be develop, and then due to this less movement, due to limited mobility will be occur. Okay, so which may leads to unrelieved pressure greater than capillary pressure. So here what will be happening? The pressure cannot be unrelieved for a prolonged period of time. It will be greater than the capillary pressure, so that what will be happening? There will be a tearing off or occlusion of the blood vessels, so that it may lead to the less blood supply and then reducing the tissue perfusion, so which may lead to the necrosis or ischemia of the skin, so which may cause the pressure ulcer. So from this to the pressure ulcer, so here you can see, when you come to the pressure ulcer, we are having these stages. So here in the stages, you can see there will be a blanchable stage 1, stage 2, stage 3, stage 4, and depth unknown. And then otherwise we call it as a pear or butterfly shaped ulcer, and then Kennedy terminal ulcer also. So stage 1, maybe it is a warmth or painful or edematous, and then in a stage 2 it is excoriations, it is filled with the blisters or like that. Stage 3 it is exposure, subcutaneous, as that we will see one by one later. And then stage 4, bone, tendon or muscle will be got exposed. Deep will be mostly removed the scar and to determine the stage. So here in a stage 2 to stage 4, it is leads to the sepsis, and then in a stage depth unknown, it also leads to the sepsis also. So if the person in a stage 4, it will be leads to the bacterial invasion that may leads to the osteomyelitis and then leads to the sepsis also. So due to the sepsis, the person may be developed with a fever, dysuria, abdominal pain, and then it may be leads to the changes in the WBC, and then high bacterial count, and then difficulty in urination. You see, the small negligence or small ignorance of a nurse, it may develop with a septic shock or a sepsis of a person. So if you can able to move relieve the pressure or friction or a shear of a person, or to remove the moisture of a person, we can prevent the pressure ulcer. Okay. So the next is a pressure. Next is a pressure. So when you come to the pressure here, you can see this is a mattress where the patient is lying down. Okay, so from the mattress there will be a pressure, and from the weight of the body there will be a pressure. Here the touching part to the mattress is a skin. Mattress is a skin. So here the pressure, here also the pressure, what will be happening? The force, it will be leads to the occlusion of the blood supply, which is in the peripherally. So here the pressure means the perpendicular load of a force extended on a unit of area. That could be a patient body weight bearing down on the hip or sacrum. It causes local capillary occlusion, reduction of blood supply, and compresses the structure between the skin surface and the bone. So the pressure exerted by the bony prominence of the body that decrease the capillary flow to the tissues, deprives the tissue of oxygen and nutrition, causing the cell death. The damage can be often caused under the skin but not become obvious until the skin avoids breakdown. So what this is telling, this is the surface pressure, this is the body weight pressure. You might have seen this is the skin which is underlying here. So here also we are having a blood supply, understand? So when it is pressure is like this what happened, this part mainly, so it is the obstruction of the or occlusion of the blood supply. So when it is blood supply is got occlusion, there is the prevention of supply of a nutrients, oxygen to the cells or a tissue which is over there. So it may leads to the damage to the skin. So once we are not releasing the pressure, it will be leads to in and it is get into the bony prominence also. So it will be leads to the breakdown of the skin, and it will be move into the until the bone. So when you come to the pressure, it is exerted by the body prominence as it leads to the surface or a body weight pressure. So it is occlusion of the blood supply of a person, and it will be leads to the skin breakdown of a person. Next is a shearing. Next is a shearing. It is the way of pushing or the pulling of the skin. So here the lay one more than a one layer of a skin sliding against each other. Oh, so it is caused as a two. These layers may become detached from each other to together. So here, if you come to the shearing, what happened here? You can see this is the shearing. This is the shearing. There will be a friction. There is a sliding of the skin. So one or two skins, it is moved together. There is a pressure. Due to the pressure, there is a friction. Friction is leads to the shear. So you might have seen there is a skin fold when you make a person in a Fowler's position. So by the time what will be happen, so here there is a friction also is come, and then pressure also it is comes, and the skin will be shearing means what it is, friction, the force is applied to the skin folds, two skins, that we call it as a shear. Next is a friction. Friction means the two surfaces rub together. the skin and the bed sheet or a chair cushion. So poorly fitting cloths or manually handling aids. Hot, moisture skin is likely to experience even more damage from the friction than more healthy skin. So if you see, this is the surface of the bed. Understand, this is the surface of the bed. So this is the body weight of a person. Body weight of a person. So what happened? It will be here. It will be rubbed together. The skin as well as the bed sheet of the person. It will be rubbed together. This is we call it as a friction. So in this friction leads to a redness, discoloration. Mainly it is happening through the bony prominent area related to sitting or lying down, related to a pressure from the device or in the wheelchair pedals. So it may be happens. So this is we call it as a friction. Friction means it is a rubbing of the skin together, that we call it as a friction. So shear means there is a force. There is a force. So here what will be happening? The friction and a pressure which leads to the shear. Okay. When you move on to the diagnostic, so when you come to the diagnostic, we are having a two type of a scale which is easily diagnosed the Decubitus ulcer. The one is Braden scale, the other one is Norton risk assessment scale. The Braden scale, it is the predicting pressure ulcer risk. It is developed in the year of 1987 with the Barbara Baden and Nancy Brickstrom. So the scale is to assess the patient risk of developing pressure ulcer. The Norton's Risk Assessment Scale, which is published in the year of 1962, it is used to evaluate the pressure injury. It is based on the mobility and the physical condition of the person. We'll see one by one. Okay, so now we move on to the Braden scale. In the Braden scale, we are having the 6 components. So the 6 components, the first is sensory perception, moisture, activity, mobility, nutrition, friction and shear. So under the sensory perception, completely limited, very limited, slightly limited, low limitation and all. So when we come to the completely limited, so here the patient with unresponsiveness to the painful stimuli or due to the diminished level of consciousness or any sedation or limited ability to feel the pain over the most of the body surface, that we call it as a completely limited. So when we come to the very limited means they can respond only the painful stimuli, communicate discomfort except by moaning or by restlessness or has a sensory impairment, which is limits the ability to feel the pain or to discomfort of the body. Okay, so when you come to the slightly limited, in the slightly limitations, they can respond with a small or with a verbal comments, but cannot able to always communicate. If you are asking a question also, they can respond to your questions, but they cannot able to communicate the discomfort. And we can ask them whether if you feel a pain, just move your hand or move your legs or wave your hands like that. Or it may has which limits ability to feel the pain in one or two extremities. So when we come to the excuse me, no impairment or no limitations. So here they can respond to your verbal stimuli, but they doesn't need any kind of a sensory perception or anything. So they can respond you with the voice, and then they can respond to you the patient is on a discomfort like that. Okay, so this comes under the sensory perception. Sensory perception is completely limited means those who are in unresponsiveness, and then those who are has the only respond towards the painful stimuli, and then those who are inner respond with a verbal command, and then but cannot able to always communicate with you, and then no limitation, they can able to verbally verbalize their pain, their discomfort and everything. Next component is moisture. So when you come to the moisture, we are having this constantly moist, very moist, occasionally moist, rarely moist. When you come to the constantly moist, so skin is kept moist almost constantly by the respirations, urine, fecal, etc. So we can detect every movement or every moving of turning of a person, we can able to identify it is moisture, like that. Often moisture means the skin is often but not always. The linen must be changed at least once in a shift. When you come to the occasionally moist, so here skin is occasionally moist, requiring the extra linen change approximately once in a day. Rarely moist, the skin is usually dry, the linen is once requires changing at routine interval, so that we call it as a moisture. So here when you come to the moisture, we are having a constantly moist, very moist, occasionally moist, rarely moist. Constantly moist, so they keep the moist skin almost constantly due to the incontinence of urine, incontinence of fecal matter, like that. Often moist, often it will be moist, but it is not moist always. The linen, the changing of the linen at least once in a shift. Occasionally moist, it is requiring extra linen changes approximately once in a day. Rarely moist, the skin is usually dry, only requires changing at routine intervals, that we call it as. Okay, move on to the next component, that is activity. When you come to the activity, here the patient is completely bedbound, chair fast, walks occasionally, walks frequently, completely bedbound, confined to bed. They cannot able to move from the bed. They were in a bedridden only, like that. Chair fast, ability to walk severely limited, that non-existent. So they cannot able to bear down their weight while they are walking. They can into a wheelchair with the assistance, that we call it as a chair fast. And then walks occasionally. Walks occasionally means it is during the daytime they can walk occasionally, but in a very short distance only, with or without assistance. They can spend majority of each shift in a bed or in a chair rather than the walking, that we call it as a walk occasionally. Walk occasionally means during the daytime they can walk very short distance and then spend majority of their day shift in a bed or in a chair. Walks frequently. Walks frequently means walks outside the room at least twice a day. Means and inside the room at least once every 2 hours during the working hours or waking hours. So once the patient is waking, they can outside the room they can mobilize twice a day, means 2 times per day, and then inside the room at least once in every 2 hours during the waking hours. So this is, we call it as a activity. When we come to the mobility, here completely immobile, very limited, slightly limited, no limitation. Completely immobile, does not make even a small changes in the body, or extremity position without assistance. They cannot able to move their position of the extremities. They cannot able to move their legs, move their hands and move their body. So that is completely immobile. So mostly we will be telling that the stroke patients, paralysis patients, they cannot able to move their extremities. So that person we call it as a completely immobile. So very limited means make occasionally slight changes in the body. So extremities position but unable to make a frequent. Means if we keep hands over the body, they can slide their hands towards sides, but not much. So it is unable to make frequent or significant changes independently. So unable to make the significant changes independently. So next we come to the slightly limited. Slightly limited means frequent thought, slight changes in the body and extremity position also independently. So mostly this will be happen to the patient, those who are underwent a surgery or something. It will be happens. No limitations. No limitations means makes majority and frequent changes in the position without any assistance. So this is comes under the component of mobility. So next we move on to the next component, that is nutrition. When you come to the nutrition, very poor, probably inadequate, adequate, and excellent. Very poor, they cannot able to complete a meal. So rarely they can eat the 3 meals, means they can eat only one meal, and they can eat only the 2 servings or less of protein, and they can take the fluid very poorly. They cannot able to take the liquids or dietary supplements, or if the patient is in NPO, or the patient within maintenance of clear liquids, or the patient is maintenance of IV fluids more than for 5 days, that we call it as a very poor. So those who are come to the very poor, they cannot able to completely take a meals, 3 meals together. Maybe they will be taking 1/3 meal, and they can eat only 2 servings. Then there is a less protein, less liquids, less water intake. They cannot able to take any kind of a dietary supplements, or the patient is in for a, or the patient is in NPO, or they cannot able to maintaining the clear liquids, or the patient is in a clear liquid or in a IV fluids maintenance more than 5 days, that we call it as a very poor. When we come to the probably inadequate means they rarely eat complete meals. Generally eats about 1/2 of any food offered. Protein intake including only 3 servings, and then occasionally will take the dietary supplements, and then receives the less optimum level of a liquids diet, or the patient is in a tube feeding. So mostly the patient is in a tube feeding or something, we call it as a probably inadequate. When come to the adequate, eat over the half of most of the meal what we are offered to the person with the proteins, meats and dairy products each day. Occasionally will refuse the meals, but usually they will be take all the supplements food what we are doing on, or the patient is in a, or with the tube feeding or TPN regimen, probably meets most of the nutritional needs, that we call it as adequate. When we come to the excellent, excellent means what all the food, what all the meals we are offering to them, they are never refuse the meals, and then they will eat total of 4 or more servings of meals, dietary products, and then they can occasionally eat between the meals. That does not leak any kind of a supplements to them, so that we call it as excellent. So this is the nutrition factor of a person. The next is a friction and shear. Next component is a friction and shear. In this friction and shear, so here we are having a problem, potentially problem, no apparent problem. So here when you come to the problem, here the person mostly require assistance to the movement, for the movement. So complete lifting, sliding, like that, they need a complete assistance. So frequently sliding down in the bed or in the chair, or frequent repositioning with maximum assistance, the person with the spasticity, contractures, agitations, that almost leads to the constant friction of a person. So that we have to give a problem. When you come to the potential problem, so moves freely or moves feebly or requires maximum assistance during a move, the skin is probably slide down. Skin is probably slide down against the sheet or against the chair, against the restraints or other devices. So here needs to be maintained a good posture in a chair and bed most of the time, but occasionally it will be slides down. No apparent problem. Moves in the bed or in the chair independently with they has their own strengths to move from the bed and from the chair, and they can able to lift themselves, and they can maintain the good position in the bed and the chair all the time. So it will be relieve the pressure, relieve the friction of that. Okay. So when we come to the scale, scoring of the scale, here we can have a score according to the components and other components things. Okay. So if the person is in a severe, it will be rate until 9. If it is a high, it is rate until 12. If it is a moderate, rate until 14. If it is a mild, rate until 18. If it is none, rate until 23. So if it is a severe and high, we have to provide a dynamic air cushion, dynamic air mattress, and the replacement of or low airless. Okay, and then we have to supplement with a small positional shift, and then we have to posture assessment of a person, nutritional assessment of the person. We have to provide education to the caregiver, and then we have to provide the education to the members of the family, and evaluation of the changing position if the person is scoring between the 6 to 12 of a Braden scale. If it is a moderate to mild, 13 to 18 of Braden scale, we have to high specification foam mattress, static overlying mattress we have to provide, and we have to provide a cushion of the chair, and then bed cradles, and then goes in next. We have to reposition weight and shifting, skin inspection, promote activity of a person, manage individual risk factors, nutrition, shear, friction, and continence. We have to provide the education to the person and then evaluate of changing the conditions. Next, we come to the none. No additional pressure support is required. We have to provide education about the weight, shifting, skin inspection, and everything, and evaluate the conditions. So this is the Braden scale and score of the scale. This is the components of the scale. So we need to apply it. Okay. Okay, next assessment tool we are moving to that is a Norton risk assessment tool or Norton subscale of Decubitus ulcer or pressure injury. So this scale has a components of physical condition, mental condition, activity, mobility, and continence. These five components which comes under the Norton subscales. So when you come to the physical condition, the condition of the patient is good. We are giving a score of 4, fair 3, poor 2, very bad 1. Come to the mental condition. In a mental condition, if the person is alert, GCS is 15 over 15, we are giving a alert, so that score of 4. Apathic, confused 14, means we are giving 3. And then if it is confused state, we are giving 2, stupor 1. So when you come to the activity, they can independently ambulate very well, we are giving 4. And then they need assistance or helps to walk, we are giving 3. Chair-bound patient 2. Bedridden patient 1. When I come to the mobility, they can move from the bed independently, or means we are giving a score of 4. And then slightly limited, we are giving a score of 3. And it is very limited, we are giving a score of 2. Immobile patient, we are giving a score of 1. Now come to the continence. There is no problem with the urine and fecal matter and incontinence of a person. So there is no incontinence, we are giving a 4. Occasionally 3. Usually urinate, we are giving 1. And urine and fecus incontinence, we are giving 1. So according to that, we are scoring the patient with the help of the Norton subscales. But basically we are using in a health sector, or basically we are using in a bedside the Braden scale. So Braden scale is the most effective method to assess the risk assessment of the patient of a pressure injury or a decubitus ulcer in order to assess the patient. So this next we move on to the common sites of Decubitus ulcer. Common sites of Decubitus ulcer. Here, with the help of the shearing force, so which of the area will be affected with this? Occiput, shoulder, elbow, sacrum, ischial tuberosity, heel and toes. And then if it is a friction, you can see shoulder, spinal protrusion, elbow, sacrum, ischial tuberosity and heel. If the person in lateral position, you can see there is a shoulder, hip, knee and ankle. So if it is a supine position, the person will be affected with the possible site of Decubitus ulcer is occiput, shoulder, elbows, spine, sacrum, heel and toes. And then some of the injury which may happen due to the medical devices. We are using a catheters, we are using a trachea, we are using a nasal cannula, we are using a facial mask, and then we are using a NGT. So all those medical devices which we are using to improve the health of the patient, so that itself leads to the pressure injury, which is related to the mechanical device pressure injury. So I showed you some of the pictures which is relevant to that. So here due to the nasal cannula, and then this is due to the mask, CPAP mask, and this is due to the oxygen supply with the help of the nasal cannula. Here you can see at the back of the yellow. So the person with the tracheostomy tube, here you can see there will be a pressure injury with IFC or indwelling catheters. You can see here with the pressure sore or with the pressure injury which happens due to the mechanical devices. So these are all the mechanical device injury you can see in case of the person within the device support. Okay, so next we move on to the stages of decubitus ulcer. So when we come to the stages of decubitus ulcer, we are having stage 1, stage 2, stage 3, stage 4, unstageable deep tissue pressure injury. We will be see one by one in a clear manner. So when we come to the stage 1, the skin is intact but may appear red discoloration. The discolored will be a blue or purple or a darker skin, and it is often painful. The red, blue and purplish area first appear like a bluish on the skin, and it may feel warm to touch and burn or itch compared to the surrounding skin. So you can see here, so this is a stage 1 decubitus ulcer. So here the skin is intact, there is no breakdown of a skin, intact skin. Here there is a red coloration, discoloration will be happen. So if you touch, it is to be touched to warmth, and it is a burning sensation to a person, and it is itching when we compare to the other skin. So this skin is normal and this skin is reddish. So this reddish may be used of the stage 1 pressure injury. In the stage 1, the skin is intact. The skin may appear red discoloration, and then it is burning and then bruising of the skin, warm to touch. When we come to the stage 2, the skin is broken, forming an open wound or a blister. The wound bed is pink or red and may be swollen. The bruise become an open sore that look like abrasions, blisters. Skin around the wound can be discolored. This area is painful. So you can see this is a stage 2. The skin is broken. Already it is broken, forming a open wound. There is a open wound and a blister. So here there is a ruptured blister is present. The wound bed is pink and may be swollen, and then the bruise become open sore. It is an open sore. It's look like a abrasion or a blisters. The skin around the wound its discoloration. You can see there is a redness of the skin will be present. So this area will be painful. This is the stage 2. The stage 2, the skin is not intact. The skin is broken, forming an open wound or a blister, and the bed is pinkish color. The bed is pinkish color. The skin around the wound, it may be a discoloration. Next, we move on to the stage 3. The wound is extended into deeper, including subcutaneous fat. It may look like a crater and have a darkened patches of the skin around the edges. The sores deepen and look like a crater, and then often dark patches of the skin around the edges. So here it is deeper into the subcutaneous tissue. So it is like epipola. So here you can see here it will be like a the subcutaneous fat, you can see here like nightly. It's look like a crater and dark patches around the edges. You can see the dark patches around the edges of the scene, ulcer. The sore deepens. It is deeper inside. It is little deeper inside, and often patches of the skin around the, you can see the patches of the skin around the wound. This is, we call it as a stage 3. Stage 3, subcutaneous fat and deeper tissue which is included, and then darker patches of the skin around the edges. Come to the stage 4. In the stage 4, the wound is very deep, extending to the muscle, bone or tendon. There may be exposed bone, tendon or muscle tissue. The damage spread to the muscle, bone or joints. It can cause a serious bone infection called osteomyelitis. It can also lead to a possible life-threatening blood infections called sepsis. So when you come to this, here the wound is very deep. Okay, so here you can see it will be involvement of all muscle, bone and tendons. There may be exposure of the bone and tendon or muscle tissue. So the damage, infection easily spread to the bone and muscle and joints. So that may leads to the infection of the bony muscles, osteomyelitis. So it leads to the bloodstream infection and leads to the sepsis of a person, that we have seen in the pathophysiology itself. The stage 4 and stage 3, it is possible to with the high risk of a sepsis of a person. Understand? So here deeper extending the muscle, bone and tendon. Here the damage is spread to the muscle, bone and tendon and joints. It leads to the serious effect of osteomyelitis, and it can be leads to the life-threatening blood infection of a person. Next one is unstageable. Unstageable means we cannot predict which stage it is comes under. So the stage 3 or 4 injury that is covered with a black dead tissue or a scar, or creamy yellow, grey, black or white thick slimy tissue slough. It's difficult to see that severity of the injury because of the covering. So you can see here, this is the wound. So here it will be affect until here, until the bone. Understand? So when the upper part we cannot see anything. It is covered by the scar tissue or dark tissue. So if it is not a dark tissue, it will be could comes under the stage 4. But it is covered with the darkened tissue. So it is we cannot see up to where it will be deeper. So it is difficult to see the severity of the injury because of the covering by the darkened tissue. So this is, we call it as unstageable pressure injury or unstageable decubitus ulcer. The next is a deep tissue pressure injury. So very dark red, maroon or purple colored area of skin that does not disappear when pressed on the dark deep wound or a blister filled with blood that is seen through a separation in the skin, indicating damage to underlying soft tissue. You can see here it is a like a dark and red or maroon or purple colored area. So if you give a press, do a blanching, so when you press also it cannot disappear, it is remain in that state only. So it is indicating underlying the soft tissue which got affected, that we call it as a deep tissue injury. So the main thing is deep tissue injury, it is a dark red, maroon or purple colored. So when you are pressing also it will not be go off, or it will be remain. So it will be indicating the damage to the underlying soft tissue. Okay, next we move on to the symptoms of decubitus ulcer. When you come to these symptoms, we are having a warning signs of pressure ulcer, unusual changes in the skin color or texture, swelling, pus like a drainage, the area of skin that feels cooler or warmer to touch than the other area, tender areas and painful. So here unusual color changes, and then texture, and then there may be a swollen areas will be present, pus like a drainage will be, and then if you touch, by the touch itself you can feel there is a warmth in the area than the other area, and the tendering areas will be present and pain also will be present. Next, the signs and symptoms the same like this, the sore areas and everything. When you come to the management, changing the position, using the support surface, cleaning, controlling the incontinence, removal of damaged tissue, dressing, oral antibiotics, healthy diet, educating the caregiver, infection control, wound intervention. So frequently we have to change the position every 2 hours of a person, using the support surface with the help of the air mattress, cushions and pillows. So frequently cleaning of incontinent patients or the moisture level is very high patients. Controlling incontinence, maybe we are putting the IFC, involving catheters, to if the person has a urinary incontinence, removal of damaged tissues and dressing with the help of other things like pressure ulcer dressing, foam dressing like that, oral antibiotics. This helps to prevent the sepsis of a person, healthy diet including with the nutritional support and proteins and dietary and everything, educating to the caregivers about the positioning of a person, and then prevention of incontinence and everything, infection control to prevent or to helps to prevent the sepsis, and then wound interventions. So we have to inform to the doctor about the concern of the wound, and then there is a need of a wound care of a person. Next is the surgical management, tissue flap, removal of the tissues and everything, and then plastic surgery, hyperbaric oxygen, and then topical use of human growth factors like a placental cream or like that, or like any other applications. It is helps you to improve the skin growth. So when you come to the diagnostic studies, MRI studies, whether we are need to find out whether it is reached the bone or not. Erythrosedimentation rate about to confirm the infectious rate of a person. So bone biopsy to diagnose the extend the wound and bacteria which is present. If it is more than 10 bacteria, we go with the surgical debridement and needs to be improve the health of the person. So next is a complication of pressure injury. So the first complication is cellulitis, and then bone and joint infections, cancer, sepsis. Cellulitis is an infection of the skin and connected to the soft tissue. It can cause warmth, redness of the affected area, and then people with a nerve damage, they do not feel the pain affected with the cellulitis. Bone and joint infection, the infection from the pressure sore, it will be into the bones and joints. It leads to the septic arthritis and osteomyelitis. It may be happening in the stage of 4, or it is unstageable. So you can see there is osteomyelitis infection can be thing, and it will be reduce the functions of the joints. So here cancer, The marginal ulcers, that's the non-healing ulcers or a wound. It's a type of a squamous cell carcinoma. So it is a long term. It also one of the complications. Sepsis, rarely a skin ulcer lead to the sepsis. Mainly it is happening in a stage 4. When we come to the treatment, reducing pressure. So first step in treating a pressure sores is reducing the pressure and friction, and it is cost is the strategies including it is repositioning. So repositioning, if you have a pressure sore, turn and changing the position of a person often, and it is generally, if use a wheelchair, try to shifting your weight every 15 minutes and changing the position every hour or every 2 hours. If you are in a bed, change the position every 2 hours. Using support surface like a mattress, air mattress, and then bed and specialized cushions. So like this can help you to sit or lie in a way that protect the vulnerable skin. And then cleaning. If the affected skin is not broken, wash it with a gentle cleanser and pat dry. Clean the open sores with the saline, and then each time the dressing should be changed. And putting on a bandage, the bandage speedy healing by keeping the wound moist and create against the barrier against the infection and surrounding the skin dry. The bandage maybe include films, gauze, gels, foams, and treated covering with the patients like this. Removing the damaged tissue, the wound debridement. So to heal the properly, wound needs to be free of damage, dead or infected tissue to be removed, debridement. So with a number of methods, gently flushing the wound with water or cutting out the damaged tissue. And the next is drugs. Mainly we are using the drugs to control the pain, non-steroidal anti-inflammatory drugs, and then to reduce the pain. And then it is helpful before and after repositioning of wound care. Topical pain medication also it will be helps. And then drugs we need to give for infection. And healthy diet, good health nutrition, which will be promote the wound healing of a person. And the negative pressure therapy, so called vacuum assist cold closure, use a device to clean the wound with suction. Surgically management, with a large sore or fails to heal, it may require surgery to cover that. There is a flap or reconstruction surgery which is more helpful to improve the wound healing of a person. So this is the management. Till now we have seen the common management of a person. The next slide we are going with the nursing diagnosis of a person. Nursing diagnosis is impaired skin integrity related to malnutrition or pressure ulcer as evidenced by epidermal or dermal tissue breakdown. So risk for infection related to wound, risk for ineffective health maintenance, and then anxiety related to treatment and recovery. When you come to the prevention, shifting your weight frequently. If you are in a wheelchair, you have to shift your weight about 15 minutes or reposition once in an hour. Lift yourself if possible. If you are enough upper body strength, or do wheelchair push-ups and raise your body seat by pushing on the arms of the wheelchair. Look into specialty wheelchair. Some wheelchair allows you to tilt them and which can relieve the pressure. Okay. And select the cushions or mattress that relieves the pressure. So we have to provide a cushion and it helps ensure your body well positioned. Do not use the donut cushions and it can focus the pressure on the surrounding tissues. Only we have to use the long cushions or like that. Adjust the elevation of the bed. If your bed can be elevated at the head raised no more than 30 degrees, this helps to prevent the shearing of a person. So this is the way and all we can prevent the pressure sore of a person. So in this video, which is help you to recollect your knowledge or refresh your knowledge about the Decubitus ulcer, and then it will be help you to apply this knowledge and apply this management while you are doing the nursing care of a person. Hope you understand well, and then hope this is very useful to you. So if there is any clarification, if there is any queries, or if there is anything, just give a message to the comments and to the WhatsApp. Let me know which are the things need to be improved and which will be whether it is very useful or helpful to you. So stay tuned. See you in another video, and then see you. Take care. Bye bye.